رحمن يا رحمن ساعدني يا رحمن اشرح صدري قرآن املأ قلبي قرآن واسق حياتي قرآن.
The next thing here is to request the speaker to stand up for the recitation of his citation. Usually when you want to give lecture, you need to inform the masses if you would not be able to stand, because usually when citation is being recited, you expect the person to stand. So, and he hasn't told us that he wouldn't be able to stand. So sorry, sir. Okay, so that is, so we're going to present a short citation of our keynote speaker. Dr. Muhammad Saddiq, as you can see, he holds MBBS from Ahmadu Bello University, the proudly largest university in sub-Saharan Africa. Now, he owns a master's in public health and a PhD in health research from the University of Sheffield, United Kingdom, with a career spanning over 20 years across governments, the World Health Organization, and academia. His current roles are that of Deputy Director of Public Health and Senior University Teacher in Health Services, Systems and Management at the Division of Population Health, School of Medicine and Population Health, University of Sheffield, a world-leading United Kingdom health research institution. Dr. Saddiq previously served as WHO's National Professional Officer for Malaria in charge of Nigeria, aiding West African countries in planning, conducting and evaluating malaria control and other public health interventions. Most recently, he served as the chair of the Health Information System Subcommittee of the Presidential Health Sector Reform Committee, leading the development of the digitalization plan for the health systems in Nigeria. I have the singular honor to present this gentleman, married with wife and children, to present today's keynote address. Takbir.
Thank you very much for that. Assalamu alaikum. My dear colleagues, brothers and sisters, as well as senior colleagues, I'm not used to doing the long protocol, so please forgive me. I'd just like to proceed with my talk. I have a few slides that I have shared with the Secretariat. I'm wondering if they're able to project it on the screen. Okay, thank you very much. So, and as you can see, I have probably mutilated the theme of the workshop, which was humanizing today's healthcare. But you could see that my take on it is a bit changed, which is humanizing healthcare in Nigeria, which is the focus. Well, mostly the same, but there are some slight kind of differences. So if you can move on to the next slide, I'll just cover some of the areas that I thought should be relevant for our conversation today. I'm going to look at modern healthcare and how far it has come. Briefly, I'm going to look at the patient journey, which is often ignored when we are designing our services, when we are delivering our services, and often even when we are conceptualizing our policies. I'm also going to look at the treatment pathways that are available to the population that we serve. And then I would make a case, which I believe most of the people here are already signed up to, which is why should we shift our focus to a more humanized, or what I would rather call patient-centered care. Thank you. The time will not permit us to go into the details of how to organize a people-centered health system or have a humanized health system, but I am going to give us some thoughts on where we can start. And then I will end my conversation with some of the bigger picture in terms of why do we have the kind of health system that we have today, and why it is so difficult for us, despite our best intentions, to provide the best services that we desire to provide for our patients. So, I think first of all, I would like to acknowledge that as health workers in Nigeria, we are operating in a very challenging environment. You face difficulties right from the point where you intend to join the medical or the healthcare profession. And some of these difficulties include limited spaces for admission. Almost all medical schools have more than the required number of people with the eligibility to get into their school that cannot go into that program. They meet the requirement, they have all the eligibility, but they still can't get in, even though we know we have serious scarcity of health manpower. So getting in is hard, but also the process of getting in itself is not always transparent. So sometimes it might be about who you know. Then when you cross that hurdle, you face an unpredictable duration of training. You know when you will start, but you have no idea when it is going to end. And it costs quite a lot compared to our level of income. So these are challenges that are already stacked against you even before you begin your journey into the profession. And then now you have completed your training, then you realize that you are in a market where there are so many of your colleagues that are unemployed. There is still, despite the high demand for health professionals, there is still massive number of health professionals that are unemployed. And for those that are employed, the pay is unlikely to take you home. So it is quite a very, very challenging scenario if you look at it. And then within the service itself, for those that are employed, you also encounter very challenging working atmosphere. We have gone through, or are still going through, a very difficult relationship between professional groups within the health sector, which is quite destructive for the industry and for all of us that work in it. So all of these factors hinder our ability to provide even the most basic of care, not to mention high quality care that our patients deserve. However, despite these challenges, I think our colleagues are very dedicated people, and we have achieved quite a lot in this country. Nigerian health workers played a vital role in dealing with some of the most difficult challenges that we face as a country. When COVID-19 came and everybody was scared, when Ebola came, when everybody was scared, it is health workers that are at the front line. A lot of them lost their lives, and a lot of them are disabled and cannot go back to work. Regrettably, we lack any memorials or honors for those heroes. Nigerian health workers also played a vital role as Nigeria was declared polio-free in 2020. These achievements are really very important to highlight because a lot of our conversation would be focusing on some of the things that are not going so well, and that will make us feel downcast, but that's not the purpose. We need to recognize some of these weaknesses, and it does not mean that we are diminishing the sacrifices of our colleagues and what they make daily, but to acknowledge that we have shortcomings so that we can improve. That's the main purpose. So I firmly believe that most health workers are drawn to the profession by the deep commitment to helping others. They come to work each day with noble intentions to make a positive difference in the lives of their patients and clients. I would also like to highlight the progress that medicine itself has achieved globally, but also in Nigeria, despite all of these odds. When I was training as a medical student, And even in my early days as a house officer in Zaria, a HIV diagnosis meant almost a certain death. But today, HIV is a manageable condition even in Nigeria. Antibiotics, my colleague, Dr. Manga, I'm sure would agree, Professor Manga, sorry. Antibiotics have revolutionized public health and healthcare overall, making once deadly diseases treatable and major surgeries such as organ transplant possible and safer. Perhaps one of the most dramatic demonstrations of the success of modern healthcare is the pivotal role that the smallpox vaccine has played in eradicating that deadly disease and the world being declared smallpox-free by WHO in 1980. In addition to these sort of well-known achievements of healthcare and the health profession as a whole, in terms of saving lives, preventing diseases, and improving well-being, there are so many roles that we play as an industry or as a sector that is not often recognized. And it is very crucial that we start to recognize those roles because we are such an important component of our society. And for this, I would use some of the suggestions or some of the points that were raised by Julio Frank, who was a former director of the WHO and currently a faculty in Harvard. He wrote a paper in 1994 on dimensions of health system. And in that paper, he identifies some of the roles that health system play in our society that we don't often pay attention to. And I'll list some of them, not all. So health systems have taken a role that traditionally is handled by individuals and families or religious or traditional institutions in our community. So if you take the simple example of childbirth, traditionally in our society, we have the elder members of the family looking after a woman that is going to deliver and looking after the child. But these days, most deliveries tend to happen in health facilities under the supervision of a trained health professional. Even something as traditional as marriages, in addition to asking your friends and your wider network to investigate the spouses, it is almost incomplete these days where you have a marriage without testing to see if any of the grooms have HIV, hepatitis, or there is pregnancy. So we play a very crucial role in that. Our healthcare services also serve a significant source of income and employment for all of us here and for many others even outside this room. Healthcare acts as a pivotal channel for mobilizing, exchanging, and redistributing substantial sums of money. This is done within government, within international bodies, but also within the private sector. I don't have the figures for Nigeria, but in 2020, the health sector contributed 17.7% of the United States gross domestic product. That's almost 20% of the GDP of America is contributed by the health sector. And I'm sure a significant proportion of our GDP in Nigeria is contributed by health sector without us actually having the figures to draw on. So we can see that we are an integral part of our economy as well. Healthcare also is a primary interface where an average citizen who has not engaged with science come face to face with science. When things happen that we don't understand, people look for explanations, and medicine happens to be one area that people tend to turn to look for explanation when things happen. Healthcare is also the focus of political struggles. This particular part is less so in our society, unfortunately. In many countries, if you think about the time when Obama was in government, he tried to bring what is called the Affordable Care Act, which is the Obamacare. That could be an election winner or an election loser for you. In fact, we know that Donald Trump has campaigned on abolishing the Obamacare, even though he struggled to achieve it. In the UK, you are unlikely to be a prime minister without addressing the National Health Service. I hope that one day our politicians will also see healthcare as a significant sector of the political system, of the political landscape. Health also embodies the meaning and interpretation of some of the fundamental human experiences, like birth, like death, like crime. It is impossible for you to make a claim of a less disease without what is called the death certificate. This is provided by the medical profession. You can't investigate rape without considering medical evidence or laboratory evidence. So beyond just improving lives, treating diseases, and saving lives, we are a key component of our society. And I will mention one other component that is ignored but also important, one which Iman, I think, stand out as an important sector or an important organization in that regard. So healthcare raises a lot of ethical questions that we need to answer as a society. And people look to us, the scholars will look to us to guide them in arriving at such ethical decisions. A few examples are things like cloning, things like gender assignment, things like artificial insemination, So these are all highly ethical, and things like euthanasia as well. In some countries, you could actually go and seek medical support to end your life. In some countries, it is legal to do that. In some countries, doctors are called to terminate the life of someone on death row. So these are all aspects of our profession that plays a part in the society. But a significant ethical dilemma that we all face in our day-to-day work, in Nigeria especially, is where you have the knowledge to treat a person, you have the solution for their problem, but they are sitting in front of you, they cannot afford to pay for it. And you have to make a decision. You know what to do, you have what to do to save the life, but you can't. And I know that Iman has done quite a lot in supporting indigent patients in our health facilities. So these are all aspects of healthcare that I want us to take into account. So now we will look at the other side of the journey. So we have built our health systems mostly to address, in Nigeria, and now to Nigeria specifically, to address our needs. I don't think we have looked enough to the needs of the population that we serve when we are designing our systems. Our hospitals especially are not designed with the patient in mind. They are primarily designed for our convenience. Our departments are distributed based on our specialties. Diseases do not always fall into those categories. And there are so many times when patients are bounced between one specialty to another, but in the end, losing vital support that they need, and sometimes it can actually end in somebody losing their lives. And I'm sure a lot of us will have experiences to share about that. Personally, I do have quite a few. So patients are not consulted on even considered when we design our workflow. The types of procedure that we're going to do for them, or how we are going to do those procedures. The equipment that we want to use, and how we want to use those equipments. My colleague, Dr. Zainab, and I wanted to do a study in the teaching hospital to look at the justification for reusing a disposable syringe in gynecological units. The common syringe is designed as a single-use syringe, but it is reused. There are cost implications to that, but we make an argument that it is too expensive for our patients, so we're going to reuse it, but did we consider all of the cost? So how do we even arrive at the prices that we set for our services? Did we think about the value that we give to the patient, whether it is commensurate with the charges that we are making? Why should the burden of the failure to prevent corrupt practices in our institutions be transferred to patients? Thankfully, I understand that the teaching hospital here has undergone digitization, but we have done an exercise about 5 years ago to look at the procedures that the patient go through and think about which of these processes really add value, which of these processes did the patient really come to get from us. And I'll just cite a few. So when the patient comes for the first time, before digitization, they'll have to get a number, and then they will go and queue up. They queue up to get the number, they queue up to go and pay for the registration, they come back and queue up and register, and then after queuing up, they queue up again for the consultation. They then queue up to get a quote. For example, after the consultation, they need to do a test, and then they go and queue up for the sample to be taken, and then they have to go and queue up again for the results. Which of these processes really add value to the patient? And why are we doing it? The reason is we feel like there is corruption in the system. We build a system that will solve our problem of corruption, but we transfer the burden on the patient. Imagine an unwell patient who has no social network and somebody to accompany them to the hospital, having to go and go through all this process. I don't think that is a human-centered service. We can go on and on, but all of this is done for our own benefit because we have failed to address a challenge that is internal, and we have failed to deploy technology effectively. I will now go through the steps that the patient takes on their journey before they get to the hospital. So if you can go on the previous slide, not this one, the previous slide, yeah. So these are some of the steps, and we use this in our course on human-centered design. This is one of the models. This is the UNICEF model. There are so many other models. And it has about 6 steps that happen before you have a patient sitting next to you in your clinic or in your lab. What happens before they get there? The first step is the knowledge and awareness. I don't think the slide is clear enough, but don't worry, I'll explain each of the steps. So knowledge, awareness, and belief about health services. Every individual, including us in this room, we have certain knowledge, we have our level of awareness of certain aspects of healthcare, and we have our own held beliefs about services that are available in healthcare. And those practical knowledge, those norms, those values, and our level of trust of the health service and the health provider shape how we engage with the service. It shapes whether we are going to go and access service in the first place. So I will give an example. There's a lot of rumor, for example, around safety of vaccines. There's a massive anti-vaxxer movement globally. Somebody that holds that belief is unlikely to come and or present their child for vaccination, even though we know the benefits of vaccination. We know that in this country, COVID-19 vaccine has not been well accepted. It might be a good reason, it might be a bad reason, but it is the belief that people have about it that shapes whether they are going to take advantage of that intervention or not. So that is the first stage. So there is need for us as health workers and also as policymakers to study some of these deeply held beliefs and understanding and take into account the knowledge, awareness, and beliefs of our target population in the design and the delivery of our services. And not wait until we encounter problem. For example, it was only when people started violently attacking vaccinators that we started, let's engage scholars, let's engage community leaders. So let us not be reactive, let's be proactive in our design. So the first step now leads you to the second step. So now you have someone who has knowledge and who has awareness and also believe that health services are relevant and useful for the problem they have. The next step is the intent. And here we're talking about the decision-making power or self-efficacy. Not everybody that intends to use health service has the right or the permission to do that in our community. We know, for example, in some situations, the husband and the father is responsible in making important decisions about whether a mother or a child can attend to a health service. We know about some consequences if they were to violate those permissions. So we need to be, as health workers, aware, culturally aware, but also respectful of community norms in design of our services. And then you cross this hurdle of intention. Now you have the permission to go and seek health service. The next step on the journey is your preparation and the cost and the effort that you need to take in order to get there. So when a decision is made to come to a health facility, patients have to consider the logistics, the transportation. They need to arrange childcare sometimes if they have other children. They need to juggle competing priorities and also the opportunity cost, especially for people who are on daily wage. So I will use an example. In Kaduna State, there was a time when the use of motorcycle was banned because of the insecurity. But we also know that people in rural communities need motorcycles to get to health facility. An emergency, medical emergency can come about, which will prevent them from going there. So when we are making our policy decision and pronouncement, I think we need to also understand how that can impact people's ability to access health services. So the costs, in addition to those logistics, the cost at the health facility can also be prohibitive. And if we add to that some informal payments, which essentially under the table payment, which is corrupt payment, which is widely prevalent in our system. There are a lot of places you go for services, they would never give you a receipt for a service that they have provided for you. So now the person have crossed those 3 hurdles, they have come to the point of service. They are now at the health facility. Again, there are some hurdles they need to cross. Some of these hurdles include the fact that health workers cannot provide the level of care that the patient wants because the healthcare workers themselves are stressed, they are overworked, or they lack the necessary equipment and supplies in order to provide efficient services. So patients may encounter lengthy waiting times, and they go through some of the processes that we listed earlier, which has no value to them. Sometimes they are even disrespected. Sometimes they are shouted upon. We've all experienced violence. If you are undergoing training in this country, at some point you must have experienced violence against patients. Then the experience of the care itself, which is the next step, step 5. When the patient gets seen by the health professional, sometimes the procedures are not done properly. Sometimes there is poor communication. They are not told what is happening. They are not told what to expect. Sometimes the environment is not convenient. A lot of women hesitate to go to health facility because the toilet facilities are unhygienic. For men, it might slightly be a lot easier. You can go around the fence and do your business. That's not easy for a woman to do. So then after the service, again, there are hurdles. Often the information that is provided is not very clear. I have seen so many patients that will leave without knowing what exactly their diagnosis was, why they came to the health facility. What is the implication of the diagnosis if they have one? What they need to do when they go home, what side effects they should expect, when they should come for follow-up, how they can contact you when there is problem. And often when they come back, the process starts as if they have never been there before. So they have to go through the process again. So that is not a human-centered service. So those are the sort of stages that you need to take into account that patients have to go through before they come and sit in front of you. But let's look at the wider population. Not everybody, so now you can go to the next slide. Not everybody even get to those steps that I listed. So here I will explore in greater detail some of the options that are available to our patients and the consequences of each of these options. For the purpose, I would employ a framework by Dahlgren and Whitehead, which is displayed on the next slide, please. This is a framework that is used for assessing health system from the public's perspective. We tend to look at our health system from our perspective, we the provider's perspective. They are suggesting that we should look at health system from the public's perspective, and that will help us design a better system. According to this framework, depending on factors such as age, your gender, your social class, the type of disease that you encounter, and the treatment that you need, and also what resources are at your disposal, you have 4 options. And I'm going to go through these options one at a time. The first option is no care. A portion of people with a health problem will receive no care for their condition. Certain minor ailments may not even require special care. In this case, no care is not a bad option. However, when there is need for care, then no care becomes a concern. It can even be life-threatening. Depending on the type and severity of the condition, no care may be the reality for the majority of our population experiencing diseases that are costly to treat. I know, as I speak, someone that's close to me who needs a surgery that's going to cost her 6 million naira. I don't think she can afford it. And this condition is going to get worse, and it might actually even lead to death. But what can they do? And we have seen a lot of adverts, and this is something Iman has addressed. So no care is one of the options that is forced on so many people within our society. Then we go to the second option, which is the informal care. A significant part of healthcare is provided informally. This is either done by individuals, the family, or friends without medical training. For example, this includes the use of over-the-counter drugs for self-treatment. In Nigeria, the vast majority of care is provided through informal means. In the 2018 National Demographic Health Survey, they found that among children with fever that are seeking advice or treatment, 58% sought care from a chemist or a patent medicine vendor or a pharmacy. In contrast, only 18% seek care from primary healthcare center and only 10% from a hospital. So you can see that the vast majority of people that seek care are actually seeking informal care. But informal care is not necessarily bad all the time. So I will look at 3 types of informal care. The normal informal care, which occurs when it is appropriate level of care. So for example, you have common cold or you have a cut, I don't think you need to bother yourself going to a hospital. You can get a plaster, or you can rest, have a lot of fluid and stuff like that, or have pepper soup, as we do in this country. Okay? So that is okay. But then we have forced informal care. And this may be the only option when necessary professional care is not available or not affordable. In such cases, households have to rely on whatever care is feasible, even though it may not be the appropriate level or type of care. Forced informal care due to limited or no access to formal professional care may have adverse social and economic and health consequences on the household. But we have a third form of informal care, which is the unhealthy informal care. When informal care or treatment is provided and has adverse effects on the patient's health or on the population health. Example of unhealthy informal care that I can give is irrational drug use. And for that, I think if you can go on the next slide, I have a prescription that I got last week. I was feeling a bit unwell. I decided to go to a PHC that is next to me. So I've hidden the name for confidentiality, but that's a real prescription I got last week. And on that prescription, you would see that I was prescribed an injection paracetamol. I walked 2 kilometers on my foot to go there. I chose to do that. So it's not like I cannot take orally. I had my breakfast before going. So there was an injection paracetamol, and then there was injection artemether. There's so many things wrong with that. First of all, why am I giving artemether as injection, and why am I giving monotherapy in a health facility that is supposed to have a trained professional? And then the third thing on that list is antibiotic. I did not see any reason why I should be giving antibiotic, but there is antibiotic there. And then the fourth thing there was a multivitamin or something like that. So I went to the pharmacy with my prescription, And the pharmacist was preparing to give me, the pharmacy technician was preparing to give me injection. And I said, please, no injections. He said, are you scared of injections? I said, no, I just don't feel I need it. I can swallow my medicine. So do you have artemisinin-based combination therapy to prescribe? So I collected that and went home. So the question is, should we consider that PHC a formal or an informal care? And then the third step. So we have looked at no care, informal care, then we come to the professional care, which is what people should get when they are not well. They should get professional care. But professional care is hampered by access. And we can look at access in two ways. We can look at geographical access. I come from Taraba State, from the Mambila Plateau, in a place called Gembu. But I come from a village called Kabri, which is 2 hours on a motorcycle from Gembu itself. So to get to Gembu from Jalingo is 8-hour journey. So I'm from Gembu, you get to Kabri 2 hours on a motorcycle. A lot of our colleagues here have been with us to Gembu, so I'm sure it's not strange to them. Yes. So imagine a woman in Kabri needing to see a health worker, but there is no health facility in their village. The only option for them to come is to come to Gembu. The cost of motorcycle from Kabri to Gembu is, one way is 4,000 naira. So how many women can afford to pay that to come? So the option is for them to walk. You know? So geographical access is a major issue from the perspective of the patient. So that can limit access to healthcare. Then there's the economic access. Even if the health facility is next door to you, and they're going to charge you 6 million naira for the procedure, and you have a salary of less than 100,000 a month, I think we can say that that service does not exist. So that's for professional service. But the worst part of this is not only that you need to have access, but even if you have the access, it doesn't mean that the access to professional care that you get is of good quality. So you have crossed the geographical hurdle, you have crossed the economic hurdle, now you are in the health facility, but you know the service is not meeting the standard. So imagine you incur all of those costs and achieve nothing after seeing the professional. And even worse, imagine you get harmed in the process. As we know, it is estimated that 25 to 40% of people that come to health facility go out with hospital-acquired infections. So they are living worse than when they came. And we also know from a very large study that was done in multiple countries that 2.5 to 18.4% of patients get harmed when they come to health facility. And that's a massive number if you think about the number of people that come to health facilities. And 90% of those harm are preventable. So no access, informal access, professional access, but what we're looking for is quality access. And to ensure quality access, our services must be of good quality. So that's why I think we should focus our attention on humanizing our health service, or what I call human-centered health services. So if you move on to the next slide, the next one. Oh, sorry, okay. So I'll just kind of round up by talking to us why this shift is necessary before ending with some concluding remarks. First of all, humanizing health services, or putting the patient at the center of our service, will ensure that we follow the first principle of healthcare, which is to do no harm. The first priority is to do no harm. It improves our treatment plan adherence. Your patient will adhere if they understand what you're trying to do and how what you're going to do is going to help them. They are more likely to adhere to the treatment. And also that helps the wider sort of public health. It fosters trust in health providers so that next time when we say people should take vaccination, as health professionals, they will listen and they will follow. But if they don't trust us on the everyday interaction that we make with them, they're unlikely to trust us when the problem comes. And then we are all going to be victims. It also helps to tailor treatments to each patient's unique values, preferences, and needs. And I'm so pleased to see Ibadah-friendly facilities. We have to take into account people's needs so that our services actually respect their values. It also ensures that we have active patient participation and reduce unnecessary tests and also cut our healthcare costs. There's so many wastes that we transfer on our patients, repeat tests that are unnecessary, other tests that we don't need, other tests that we never use in our decisions. I have water, please. So also it promotes shared decision-making and encouraging healthier lifestyles. It upholds patients' autonomy, and it also facilitates better understanding of medical condition and treatment options. For some people, they may not even take the treatment that is on offer if they understand that this is a problem that is going to go away and they are willing to tolerate whatever inconvenience that might come before it goes. Thank you very much. So, where do we start? So, humanizing healthcare is not something that you do. It's not something that you do, but it is how you think. It is about how you think. It requires a shift in mindset. And to achieve this, you must prioritize the needs of the people who would use your service. You place them at the center of your design and your processes. You only provide to them what adds value to them. And you also take into account all of these hurdles they had to cross in order to be there in front of you. If we have that at the back of our mind when we're designing our workflow, I think we will have better services. And while we could dedicate, I believe we could an entire lecture to delve into the intricacies of human-centered design, we have courses that run over a week or 2 days. I don't think we would be able to do that here. So such a deep dive would exceed the scope of this talk. However, I am more than willing to engage in discussion on the sidelines or any other feature workshops to take us through human-centered design or patient safety or clinical governance, as we have done with the Federal Teaching Hospital and AKTH about 5 years ago. Sure. So I think that is about humanizing healthcare, but why is our system the way it is? The bigger picture, so I'm going to end on that note. Up to this point, I think my discussion has centered on what can be realistically applied within the confines of our local institutions, but I am fully aware of the constraints enforced by the environment in which we operate. And as I initially highlighted at the beginning of my talk, this constraint stems from the fragile foundation upon which our healthcare institutions are built and the inadequacies in our governance of our health systems. So it might be slightly off the topic, but I think it's really important because of the audience to understand why is our health system the way it is. I think there are 3 fundamental things that we have not addressed as a country and as a sector in relation to health. And these 3, thank you. So these 3 factors, they would sound logical to you, but it is something that I find it hard to get it into even the highest level of policy making. Even within the presidential committee, this is not something you can easily say and people will pick up and go with. The first one, I think we have not yet been able to define who is responsible for healthcare in our country. Who is actually responsible for this healthcare? Is it my individual responsibility? Is it the responsibility of us as a collective? Any country that you know, pick an example, anywhere in the world that have a good health system, there is clarity about responsibility. If you live in the United States, You know that your healthcare is your responsibility. You have to seek out your health insurance. You know, anything that the government does to you, it is just helping you in order to meet your own individual responsibility. The government can decide to prioritize some people, like veterans, the aged, and say, okay, we are going to give you, which is covered by the Affordable Health Care Act. So you don't have employment, you don't have your age, you are a veteran, you know, the government has picked up the tab. It is not taking up that as a collective responsibility, but it is looking at that as a support for a priority group of people. That is different from a country like the United Kingdom, where healthcare is a collective responsibility. In the UK where I live, nobody needs health insurance. People do take health insurance if they want, but you don't need health insurance to access service. Nobody asks you about money when you go to the health facility. All you need to do is to present your number, they will ask you your date of birth, they'll pull up your record, they will see you. If you need referral, they will refer you. If you go to the hospital, nobody asks you about money. If the hospital doesn't have what you need, if your treatment is going to be in the US, the hospital will pay for you to go to US, they will pay for your transport, they will pay for your accommodation, they will pay for people that will go with you. If your children have to be with you for a long time, they will pay for the schooling of the children there, and then you come back. Because the society have decided that healthcare is a collective responsibility, not an individual responsibility. But if you look at our Health Act, you look at any of our policy documents, there are conflicting information. Here we are talking about health insurance, which suggests to you that health is individual responsibility, you need to get premium and this and that, but then you hear declaration, oh, we're going to provide free maternal services, or we're going to provide, we are paying for input salaries for health workers, we're paying for building hospitals, we're paying for that. Which one are you doing? So that creates a bit of a confusion within the system, and as long as that is not disentangled, we are not going to have a foundation upon which to build a health system that is coherent and consistent. And if we decide as a country that healthcare is a collective responsibility, at what level do we apply that collective responsibility? Is it at the federal level or is it at the state level? If it is at the federal level, do we have sufficient solidarity for someone in Lagos will feel the obligation to pay for the health care for someone in Jigawa? If we say it is a state-level responsibility, how do we deal with our own mobility when you move from one state to another? You know, but these are all details. But once it is clear where we allocate the responsibility, we can start building from there. So that's the first point. The second point where we have issue within our health system is that we assume that our rules actually work. We have a Health Act that was signed in 2014. I can guarantee you that not 10% of what is in that law is applied. So because you write something as a rule, it doesn't mean it is going to work. So we have to recognize that we do not have the capacity to enforce even our laid down rules. And then we have to start looking at what are the rules that are actually working within our system. We are an organized society, despite the chaos that might appear, because we feel safe to come here in this room and sit, engage with each other, because there is some order, there are certain rules that we follow. What are those rules, and how can we take into account those rules when we are designing our systems? And then the final point that I will make is around availability and distribution of knowledge. I think we have, there is insufficient availability and poor distribution of knowledge. And by this, I mean knowledge in terms of as embodied in the health worker themselves, the skills and knowledge that the health worker has, but also knowledge as embodied in the technologies that we use, like the medicines, the vaccines, the tests that we use. These are all somebody else's knowledge that has been packaged into a product. How this knowledge is produced in this country is over-centralized or left to a chaotic market. I think we need to have a more distributed system of knowledge. Why should we have all of our professional medical doctors trained in a teaching hospital when we have so many general hospitals all over the states where they have volumes of patients, where they could go and see more patients, hone their skills? All you need is to have someone who is qualified to supervise the training there, someone who is certified as a trainer to be in that general hospital for those procedures, and then the person that trained there, once the trainer is satisfied that you can meet those requirements of doing those procedures, they sign you as competent for that. You move on to the next step. And this is done all over the world. It's not new. So why should we concentrate everybody in the hospital where they're dealing with very few patients? Teams can only work on one day, when they could work for 5 days, because the other team need the theater, the other team, So there's so many economies of scale that we are losing, apart from losing the source of our training, which is the patient. The other thing is about technology, why should the government, set up an agency, for example, to produce a vaccine? Why don't the government create the right incentive or the funding for private individuals to set up these services? As we can see with our refineries, government are not very good at setting up businesses. And you need a lot of business thinking to produce health technologies because the regulation, the requirements to meet are quite vast. So I thank you so much for this opportunity, and I congratulate you for the timely recognition of the need to start thinking about how we make our health system fit for our population and address their needs. Thank you very much.
Jazakallah khair, sir. Can we say Jazakallah khair to our keynote speaker? May Almighty Allah reward him abundantly and increase him in knowledge and understanding. So, for those who might be attending conference for the first time, we don't usually take comments and questions on keynote address, so we're not going to take that here. So we have listened to him, and the speech is very, very key to healthcare. I think towards the last part of his slides, he told us we need to circulate our health workforce. I think that's a very nice one. We have many CMDs sitting down here. We have many MDs sitting down here. I think that is a very big take-home message. Let's see how to create a roster of rotating our staff to some of these local areas. It's going to help improve healthcare. Thank you very much, Dr. Saddiq, for that wonderful keynote address.
رحمن يا رحمن ساعدني يا رحمن اشرح صدري قرآن املأ قلبي قرآن